Hi, my name is Charlie Nutting. I'm an interventional radiologist in private practice in Denver, Colorado. I'd like to thank LACNETS today for inviting me to speak about liver-directed therapies. Why are treatment of liver tumors important? Well, about half the patients who present with neuroendocrine disease will have liver tumors at the time of diagnosis, and that increases up to 90% over their lifetime. Liver tumors, by their nature, start to replace the normal liver tissue and can push the normal liver tissue out of the way. So it's our job to try and keep the liver as healthy as long as possible. By treating these tumors, we can help preserve the liver function and also decrease symptoms related to these tumors. We've known for years that cytoreductive therapy or debulking of the tumors is going to help patients long term. Number one, it helps decrease symptoms such as diarrhea or flushing, and it can also help preserve liver function over time. Those are the main goals of cytoreductive therapy. As an interventional radiologist, when I look at patients, I look at their imaging, and we can see that this patient here on the left side has one small tumor in the backside of the right lobe of the liver. That's that little black dot. And that's a very different disease than we see in the patient on the right side who has multiple black dots spread throughout the liver. Those livers are actually treated very differently. So how do we decide which tumors to treat in which fashion? Well, if you have relatively small tumors that are less than 3 centimeters in size and less than 3 in total, we can use local ablative techniques. Patients who have more diffuse disease that spread throughout the liver, both sides, or in difficult to reach locations, then we'll consider regional liver therapies. Local ablative techniques. The ultimate local ablative technique really is surgical resection. So if you can take that tumor out, that's the best way to get rid of it. There are also minimally invasive procedures that allow us to insert a needle and either heat up the tissue with microwave or radiofrequency ablation. We can also freeze the tissue with cryoablation, or in special circumstances, we can shock the tumor into dying with irreversible electroporation. This is just a cartoon of a microwave ablation, but it can be translated into other ablative techniques. With microwave ablation, we're inserting a needle, which is really just a sharp antenna, into the tumor. We then turn on the energy that creates frictional energy and heats up the tumor to the point where it cannot survive. On this pre-procedural image, we see that there's a 3 centimeter tumor within the backside of the right lobe of the liver. That's the dark area there within the circle. We turn on that energy. Usually takes about 10 to 15 minutes to desiccate the tumor. The 6-month image shows that this area is dead. There's no contrast enhancement in that area. And at 1 year, we can see that cell death persists, and there's been a little bit of scarring of the liver with capsular retraction, which is actually a good sign of treatment. As we move on to regional liver therapies, or if the disease is too diffuse to put a needle in or do surgery, then we start looking at treating these tumors through the arterial system. Embolization just means that we're putting a product into the artery that gets carried downstream. Bland embolization is just a bead that creates ischemia and cell death. Chemoembolization is where we mix these beads with chemotherapy, and that chemotherapy dwells in the area along with the ischemia. Drug-eluting beads are beads that are soaked in chemotherapy and infused into the artery. Once they hit their location, they slowly elute chemotherapy, and there's actually been some issues with this technology in neuroendocrine patients that we'll address a little bit later. Radioembolization, the particle contains radioactivity, and then there's also isolated percutaneous hepatic perfusion. Regional liver therapy is accomplished by inserting a small tube into the arterial system, usually from the groin or wrist area. Under X-ray guidance, the catheter is then advanced into the blood supply of the liver. A smaller catheter or microcatheter is manipulated into the blood supply of the tumor itself. Small beads are then dribbled into the arterial blood supply. These travel downstream and become lodged at the precapillary level, where they exert their local effect. This technique is the same whether we're performing bland embolization, chemoembolization, or radioembolization. These therapies help kill the tumors from the inside. The NCCN guidelines call out liver-directed therapy for liver-dominant disease. And when we get to this category, there are specific caveats that they talk about. There has not been a study, a prospective randomized controlled study, looking at bland embolization versus chemoembolization in patients being treated for neuroendocrine disease. So in general, these therapies are considered comparable. Drug-eluting bead recently in the Remnant trial has showed that there's an unacceptably high complication rate with some biliary complications. So that really has been taken off the table. Most patients are being treated with bland or chemoembolization. TARE or radioembolization has been shown to be safer in patients who have bilioenteric anastomosis, which means that they have had a Whipple procedure. They could have a stent in their biliary tree. It's safer to treat these patients with Y90 than it is with bland or chemoembolization. And there's also some data that's coming out demonstrating that Y90 may have some toxicities, long-lasting toxicities, because we know neuroendocrine patients are going to survive for a long time. So really, we're looking at the long-term gain. When we talk about embolization therapy, what are we trying to accomplish? Well, in general, you want to make patients feel better and control their symptoms. We want to improve overall survival, and we want to provide local control in the area of the tumor to keep the liver healthy as long as possible. Some of the questions that come up is, are these therapies safe? How long do they last? And then specifically with Y90 radioembolization, can that be used after patients have received PRRT? This is a meta-analysis from 2012 looking at clinical response in patients who had transarterial chemoembolization, and 85% of patients derived significant benefit from chemoembolization. So this is really a well-tested therapy that works great in patients that have liver-dominant disease. We also want to try and debulk these tumors. This is radiographic debulking, looking at patients who have been treated and then do follow-up scans. And up to 89% of patients do get significant debulking with a mean of about 55%. So it is safe, it is effective. This is a study, actually a survey in 2012 of interventional radiologists discussing how they treat these tumors based on tumor type. So in metastatic neuroendocrine disease, we can see that it was pretty evenly spread between particle embolization, bland, drug-eluting beads, Y90, and chemoembolization. I would say that this has probably shifted over the last 3 to 5 years to much more bland and chemoembolization, with radioembolization being used subsegmentally. It's important for you to talk to your physician, your interventional radiologist, about how are they going to prophylax you against a carcinoid reaction in patients who have functioning tumors. So at our institute, we give IV octreotide, usually 100 micrograms, subcutaneously or intravenously right before the procedure. In patients that we know are labile, have labile disease, because as we embolize these tumors, they're going to get angry and secrete their proteins and hormones. We will mix up a bag and we will titrate it, or we'll drip it in based on symptoms. And it's very easy to speed it up or take it down. We tend to run the octreotide for about 2 to 4 hours after the embolization procedure. We're going to look at a couple of papers here. This is a multi-center retrospective review on 244 patients who have neuroendocrine liver metastases that were treated with resin spheres, or the trade name is Sursphere. You can see it's uncommon for the tumors to go away, which is a complete response. It's much more common to see a partial response or stable disease. And only 9% of these patients actually had progression of disease after the radioembolization. The symptoms were alleviated in 79% of patients, and it was uncommon to have complications, but those complications could include a gastric ulcer if the beads go outside of the intended vascular bed, or RILD, radiation-induced liver disease, which we'll talk about a little bit more. This was a study out of Northwestern University looking at long-term hepatotoxicity of Y90. It was a single center review, and they followed these patients for 2 years after the radioembolization. They looked at 54 patients, and they used glass microspheres or Theraspheres, which in general tend to be hotter, a more radioactive sphere than the Sursphere. And they saw that 27% of these patients developed a scarring of the liver. It looks like cirrhosis, and 13% of them developed ascites. It was more common in patients who received whole liver treatments versus lobar infusions. And by lobar infusions, I mean right lobe, left lobe, and you can also infuse the segments. There are 8 segments within the liver. So the less liver you treat, the safer the therapies are. This is a single center review looking at hepatotoxicity by Dr. Curry. The interesting thing about this is they looked at both Y90 products, Sursphere and Therasphere. Only half of these patients had neuroendocrine disease, and what they saw was RECT or RILD occurred in only about 13% of patients, and it was more common with the glass spheres than it was with the resin spheres. Is Y90 safe after receiving PRRT? This is a multi-center retrospective review looking at 44 patients who underwent Y90 procedures after PRRT. There's still good disease control rate of about 91% at 3 months, clinical response in 65% of patients, and the overall survival was 3.5 years. There were toxicities, but they were relatively rare, with lymphopenia, meaning a decreased white blood count that rebounded, and RILD, which is radiation-induced liver disease, in about 2% of patients. Dr. Sulin and others also looked at this patient population and found that people or patients who had been heavily pre-treated with liver-directed therapy and received PRRT did have some significant adverse events. So if we look at the outcomes from embolization therapy, it does control symptoms in 75 to 80% of patients. We are good at debulking the disease, and the durability is somewhere between 18 and 30 months. Y90 is safe and effective after PRRT, and really what we're trying to do is keep the liver as healthy as we can for as long as possible. Morbidity or serious adverse events is relatively rare with a very low mortality rate. This is a study that Dr. Sulin has put together. It's a randomized controlled trial, which is really the gold standard in medical therapy, looking at bland embolization versus chemoembolization versus drug-eluting beads in patients with neuroendocrine liver metastases. This is ongoing. We don't have the data yet. The drug-eluting bead arm has been dropped due to an interim analysis evaluating and identifying increased toxicity. Some of the other procedures that we have available in interventional radiology is portal vein embolization. Portal vein embolization allows us to treat the affected side of the liver and grow the other side of the liver. These patients who are going to undergo surgery to remove a portion of the tumor need to have enough normal liver tissue to survive. So if a patient has a right-sided tumor, we can do a right-sided portal vein embolization, grow the left side of the liver prior to surgical resection. We can also do the same thing with radioembolization. This is a patient who has large right-sided liver tumor burden. They underwent high-dose radioembolization of the right side to treat the tumors and to actually grow the left side of the liver. The patient underwent surgical resection to have the right side removed, and there was no evidence of disease on follow-up scans. Our clinical practice in Denver, I'm very fortunate to work with Dr. Eric Liu and Alan Cohn at the Neuroendocrine Institute at Rocky Mountain Cancer Center. We have multidisciplinary tumor boards that allow us to discuss patients, review images, talk about sequence of therapies, and it really is a multidisciplinary review board. The way that we treat liver tumors, we tend to use bland embolization in a lobar fashion, meaning that if patient has diffuse bilobar disease, we would treat the right side of the liver first with a bland embolization. Patient would recover, come back 1 month later, and we treat the left lobe. Dr. Liu also has a program of sequencing bland embolization in between PRRT. We really reserve Y90 for segmental or unilobar infusions. Occasionally we'll treat whole liver, but that's much less common than it was in the past. We'll use high-dose radioembolization, or as we call it, selective radioembolization for difficult surgical areas. So tumors that are in segment 7 and 8, which is underneath the right side of the diaphragm, or central tumors are difficult to surgically remove, we'll use high-dose Y90 in those settings. Most of our procedures are performed in the clinic or outpatient hospital setting. It's relatively uncommon to admit patients to the hospital. On the left side of this picture, a patient has 2 tumors in the left lobe of the liver. Those are those brighter white spots that we see. This was an MR that was taken 1 month prior to the radioembolization. The middle live picture is injection of contrast material into the left hepatic artery. You can see those tumors blush or light up, become darker because of the increased blood supply that they have. So this was segmental radioembolization of 2 left lobe liver tumors. And then the right-sided MRI demonstrates the lack of blood supply or darkness, which is necrosis in the area where those tumors used to be. So in conclusion, embolization therapy is effective at debulking and helps control neuroendocrine liver metastases. And the real key of all this is to keep the liver as healthy for as long as possible. It's important to sequence these things, whether it's biologics, chemotherapy, or surgery and liver-directed therapy. And I really think collaboration is key. With a complex, relatively rare disease, it's good to have a team of people discussing you. I would stay away from drug-eluting beads in general for neuroendocrine tumor embolization. It is safe to use Y90 in lobar or segmental infusions, and you can treat patients who have undergone PRRT in the past. I'd like to thank LACNETS for allowing me to present this, and hope you guys have a great day.